We'll give it one more minute as folks join. I think we should begin. You think so? Okay. All right. Hi, everybody. We're going to start our program, and there'll be participants joining in over the next couple minutes, but we'd like to start on time. I wanted to say thank you for joining us this evening at the start of summer, end of school year for many of you or some of you. I'd like to introduce myself briefly. My name is Allison O'Hara. I am the Executive Director for Oneinforty. Once again, thank you for taking the time to join us this evening. We've allotted about 45 minutes for this evening's webinar. A recording will be made available on our website at www.oneinforty.org. I also wanted to let everybody know that we've received some questions for tonight's webinar. Should you have a question for Dr. Ellisen, there's a chat or a Q&A in the lower portion of your screen. Please feel free to type in your question, and we'll get to those once our Q&A portion of the program starts. I'm very excited, and we are very honored to have Dr. Leif Ellisen this evening as our guest speaker. Dr. Ellisen will be sharing more information about the Oneinforty risk, reasons for screening and testing, and also sharing some very exciting new news as it relates to, I know maybe you can add to that, but as it relates to the BRCA gene mutation. So we'll wait for his presentation in the next few minutes. Before we get into Dr. Ellisen's presentation, I wanted to briefly just thank our partners for this evening, the AbbVie Foundation, Combined Jewish Philanthropies of Greater Boston, New England Development, and Goldstein and Philadelphia. So before we get started, I just wanted to briefly share, some of you already are very familiar with Oneinforty, but for those folks that are attending this evening, where it's your first time maybe attending our program, I just wanted to share a little bit more about Oneinforty. So as you can see, there's a picture of our founder and one of my dear friends, Lauren Kordak. Lauren founded Oneinforty around 2017, and unfortunately, this past December, Lauren passed away from stage 4 ovarian cancer due to the BRCA gene mutation. Lauren was just 49 years old. She was just short of her 50th birthday. Lauren began Oneinforty. She set out on a mission to educate the community, the healthcare providers, policymakers about the Oneinforty risk. And as we continue to mourn the loss of Lauren, we are committed, along with our medical advisory board and our board of directors, to really continue the important and life-saving work Lauren had started. For those of you, again, who are new to us this evening, we are a nonprofit organization that helps to raise awareness of the Oneinforty risk to Ashkenazi Jews of inheriting BRCA gene mutations, and we help to provide the support that individuals and families need to effectively manage their cancer risk. I would now like to introduce our guest speaker for this evening's webinar, Dr. Leif Ellisen. If I've left anything off, Dr. Ellisen, please let me know. Dr. Ellisen is the Program Director of Breast Medical Oncology. He's also a Professor of Medicine at Harvard Medical School. He is the Clinical Director of Breast and Ovarian Cancer Genetics at Massachusetts General Hospital. Dr. Ellisen? I'll stop sharing right now, too.
Thank you very much, Allison, for that kind introduction. And thank you everyone for joining this evening. I hope you can see my slides okay.
Yes.
So what I'd like to talk about this evening is to give you some of the basics and some of the recent updates about hereditary breast ovarian cancer, the BRCA genes, the prevalence of BRCA and its importance in the Ashkenazi Jewish population. And the underlying theme of my talk is that as each year goes by, the importance of knowing your risk and particularly knowing your BRCA status becomes more and more important. I'm going to talk for perhaps 20 minutes or so, and toward the end, I will be taking you through some of the most important clinical data that has ever been produced, underscoring how knowing BRCA status can save lives. And I think it's very exciting. And so I hope everybody will be able to hold on to the end for that. In the meantime, I hope to give a mix of the basics and some new updates for folks who might not be familiar with the field, as well as for folks who are really seasoned in many of the basic concepts. So if we look at breast cancer as an example of hereditary cancer, like many cancers, a lot of cancer is not so much a hereditary risk, but caused by aging and the accumulation of mutations. It turns out, though, that more and more knowing about hereditary cancer and whether your cancer might be hereditary is particularly important because it leads to new diagnostic options, new ways to prevent the cancer, and in particularly new and more effective ways to treat the cancer. And so what that means is, whereas in the old days, 20 years ago or more, when I started my practice, knowing whether your cancer was hereditary or not might be important to some degree for your risk, it had limited implications. But nowadays, knowing your hereditary possibility, and particularly in the setting of BRCA1, 2, even if the chance for you might be small, knowing that could be life or death knowledge in terms of the better treatments that are available in the setting of hereditary cancers. And so that's a really important message, which with every year going by becomes more clear. So if we think about the whole scope of genes that cause hereditary cancer, and here is an example for hereditary breast cancer, it turns out this is kind of a complicated chart, but basically what it says is that if a certain gene, when inherited in a mutation, is a cause of very high breast cancer risk, it tends to be relatively uncommon in the population. That's here at the upper left. Whereas certain variants of genes, which by themselves are not too meaningful, can be very common in the population and only affect risk in a minor way. And this is a chart that we've known about for many years. We have high breast cancer risk genes in the upper left, what we call moderate risk genes in the middle, and then these so-called risk alleles on the bottom right. Well, really what's new lately is a better understanding of how common BRCA1 and 2 are in the population. And the 1 in 40 risk for Ashkenazi Jewish individuals for BRCA2 is one example of that. But also what's new, as in the not too distant future, we might be using these lower right, what we call risk alleles. These can influence the way a BRCA1 and 2 mutation behaves and might influence risk in an individual who carries BRCA1 or 2. So in the future, we might test for all these different genes because the interaction of them might tell you whether your risk with BRCA1 is on average higher or lower than the average BRCA-associated risk, which generally is high. So there's more power to interpret genetic testing as time goes by. So what is the basic nature of hereditary cancer? I always include this slide because I think it tells something about the fundamental basis of cancer. Generally, most cancers, as I said, are caused by age-associated mutation that occurs in what are called somatic cells. That is, they're not hereditary. It's in our normal cells. And when mutations accumulate, particularly if we knock out 2 copies, of course, we have 2 copies of each gene in every chromosome. And if we knock out 2 copies of a good gene, that can lead to tumor development. But of course, you have to knock out both copies in one cell for that to happen. In a simple way, the reason why hereditary cancer is much more common is the nature of hereditary cancer is that a non-working or a defective allele or copy of one of those genes, and this would be a BRCA1 or a BRCA2 gene in this case, is already inherited. So the individual only has one good copy to lose. So simply the difference in the probability of losing one copy versus two copies in a simple way explains why hereditary cancer and inheriting a BRCA1 or 2 mutation is associated with a much higher risk of certain cancers. 25 years ago when these genes were cloned, everybody thought immediately we would know why BRCA1 and 2 are mostly associated with hereditary breast and ovarian cancer. It turns out, however, that still to this day, we don't have a good handle on the biologic basis of why BRCA1 and 2 seem to be relatively selective in the cancers they predispose to. And much research on that is still underway. So to remind everybody what we're talking about with BRCA1 and 2, because so much about this is awareness, and awareness is empowerment, knowledge is empowerment. This is what we call the pedigree or the family tree, where circles are women, squares are men, and you see each generation. These are what we could, this is the first generation, these are the parents, and these are the grandparents. And with BRCA1 and 2 inheritance, you see a pattern on one side of the family with an index patient with a young breast cancer who had an aunt with breast and ovary cancer, early breast cancer, and ovary cancer, all the hallmarks of what's called hereditary breast and ovarian cancer syndrome, or BRCA1 and 2 associated breast and ovarian cancer. This is the classical finding that is easy for many people to recognize, but the family history can be subtle, as I will reinforce, and that's why knowing about your family history, and particularly if you're Ashkenazi Jewish, seeking testing is important. So what are the actual hallmarks for any individual who might have hereditary breast and ovarian cancer? This is in the general population and something for every individual to be aware of, and particularly women. Anybody with ovarian cancer or a close relative with ovarian cancer, triple negative, an aggressive form of breast cancer, or a relative, close relative with that. Breast cancers before age 50 or a close relative. Male breast cancer, which as we know is relatively uncommon, but is a hallmark of BRCA1 and particularly BRCA2 associated breast cancer, and individuals who have multiple primary cancers, particularly breast and ovary cancers. So this is true for anyone in the population to be aware of these signs in their family history. But of course, regardless of your cancer history, there are certain things to be aware of, and the most important of which, from the point of view of BRCA1 and 2, is knowing about Ashkenazi Jewish ancestry, right? And as we know, this is not about your religion, it's about your lineage and descendants from the Eastern European Jewish population, in which BRCA2 mutations arose thousands of years ago and have remained in the population. And that's the reason why the Ashkenazi population has a higher rate of BRCA2 than virtually any other population on Earth. Of course, if you know that you have relatives who have a BRCA mutation, that may be an indication to be tested for these genes as well. Now, over the years, through analysis of thousands of women and families, we've gained a better awareness of what the risks with BRCA1 and 2 are. And one of the things that is somewhat overlooked sometimes is age-associated risks. If you think about breast cancer in the general population, breast cancer is largely a disease of older age, largely a disease of the 50s, 60s, 70s, and 80s, and sporadic or non-inherited breast cancer. Every year a woman gets older, her breast cancer risk is slightly higher than it was the year before. The pattern with BRCA is quite distinct. Not only is the risk of breast cancer higher, so risks to age 70 or 75 up to 80% for BRCA1 and nearly as high for BRCA2, but importantly, once a woman reaches her 30s, her risk over time is relatively constant. So for example, in my practice, when I see a woman who might be 35 years old, and she says, well, maybe I don't care about what's going to happen 40 years from now. Tell me what my risk could be of getting breast cancer in 5 years, or tell me what my risk might be in 10 years. And it turns out for BRCA, that's relatively straightforward. The average risk per year of a patient with BRCA2 is about 1.5%. So a 35-year-old woman with BRCA2 in the next 10 years, 1.5 times 10, she has a 15% chance of developing breast cancer in 10 years. Women with BRCA2, 2% per year. So in 10 years, a woman with BRCA2 who's 35 has about a 20% chance of developing breast cancer in the next 10 years. So it's this risk over time that is actually often the most helpful for folks who are making decisions about how to manage their risk. And that's something we'll talk about momentarily. Ovarian cancer risk, it's important to note that the risk is substantially higher with BRCA1 than it is BRCA2, but the key feature associated with age in BRCA1 versus BRCA2 is that most ovarian cancers with BRCA2 happen between 5 and 10 years later than ovarian cancers in women who carry a BRCA1 mutation. So that means that women who are thinking of ovarian cancer prevention, which we'll talk about, for BRCA1, those women have to start thinking about it in their 30s, whereas women with BRCA2, by and large, unless their family history is unusual and there is a very early ovarian cancer, except in that circumstances, women with BRCA2 don't really have to worry so much about what to do with ovarian cancer risk until after age 40. They don't typically have to have ovarian cancer preventive surgery until after age 40. And again, this is based on well-founded data over really 20 years of family studies. Now, within an individual family, we never make recommendations just based on the gene in the same way that we wouldn't make recommendations without looking at the gene. We have to put together for any woman to make risk recommendations, the gene, her own personal history, and her family history, because things like hormonal exposures, pregnancy can affect risk of breast cancer, and the family history. The same BRCA1 or BRCA2 gene can behave differently, more or less aggressively in different families. And that can be hard to pin down, but often looking at the family history can give one a clue, and it's very important to do in the context of making individualized, patient-specific recommendations for managing risk. So I want to go back again to the question of the family history and why it's so important to think about your family history, particularly if you're Ashkenazi Jewish, but anyone, and to point out some of the challenges in interpreting family history for folks to think about if one is thinking about, gee, should I think about genetic testing? So this is, again, a pedigree. You have 1, 2, 3, 4 generations here, and you have a woman that the yellow means a cancer developed. This is a woman who's 44 who developed breast cancer. Okay, so she's 44, she developed breast cancer, but she has no family history. She has lots of relatives. She has no family history of breast cancer whatsoever. Does this woman require genetic testing? Should she even think about it? So what are the key features here in the family history that says, yes, this is a woman who really needs genetic testing, even if she's not, in this case, Ashkenazi Jewish? So this is a woman who, for example, on her paternal side has very few female relatives, right? Father had no sisters. And remember, the BRCA1 and 2 gene can equally be inherited from the paternal side as it can from the maternal side. For example, Lauren Kodak, the founder of Oneinforty, who was a much beloved patient of mine whom we miss every day, one of the reasons she was not fully aware of her potential risk was that her mutation was transmitted through her father's side, which, as in this case, makes it more challenging to identify what the risk is because there's fewer women. In addition, in this case, the woman had triple negative breast cancer, which is a hallmark of potential genetic breast cancer. And indeed, this woman did seek testing and did have a BRCA1 mutation. Another scenario which commonly comes up is this one. A woman is 53 years old and she has almost no breast cancer history. She has an aunt who had breast cancer at a relatively late age, so it doesn't look like hereditary breast cancer. Zero breast cancer history. And the woman is 53 and she's never had breast cancer. Is there any reason this woman should think about genetic testing? In this case, again, it's a woman who's not Ashkenazi. If she is Ashkenazi, she should have genetic testing. But what if she's not? Does this woman need genetic testing? The key hallmark here is that she has no living cancer-affected relatives, and in particular, her mother developed ovarian cancer. Now, if the mother was living, the most important thing to do would be to first test the mother and determine whether the mother had a mutation. But because the mother is not living and can't be assessed, the daughter definitely needs testing, just as if she herself had developed ovarian cancer. Again, I'll say it one more time. If the person who is affected with the cancer can't be tested, the first-degree relative should be tested. And in this case, again, the woman carried a BRCA1 mutation. So these points underscore the importance of understanding your family history and the pitfalls in interpreting the family history. Now, this is based from a study that we did a few years ago, and the blue lines just indicate BRCA1, 2 in women with breast cancer, different features, triple negative breast cancer, they develop breast cancer under 35. The most important thing to take from this slide is the highest bars. This is testing for a whole panel of breast cancer mutation, either BRCA1, 2, a group of moderate to lower risk breast cancer and ovarian cancer mutations, or other mutations associated with ovarian cancer. And the high dark blue bars tell us that BRCA1 and 2 are the most important causes of hereditary breast cancer. But there are other genes, and so these genes are not necessarily more common in the Ashkenazi population, but they still are present in the Ashkenazi population. And women who are Ashkenazi, and any woman with a significant cancer family history, as we've talked about, might consider testing for this whole panel of genes which are related to breast cancer risk and can change management for breast and other cancers. And I won't go through the entire table, but just to say that most women now undergo testing not only for BRCA1 and 2, but something called a multigene panel test. Many commercial companies do this, and the panels have different names, but they test somewhere between 8 and 30 genes associated with breast and ovarian cancer. And the implication of each gene is different. Most of the genes do not have a higher risk as BRCA1 and 2, the exception being a gene called PALB2. You should pay attention to PALB2 because it's very much like BRCA2 in its behavior, in its risk, and how the cancers might be treated. The others are associated with lower risk of breast cancer. For example, the ATM gene, 20% risk versus 80% for BRCA1, but importantly are also associated with risks for other cancers, such as pancreas and ovary. There actually is a nationally approved guide that all the experts get together every year to go over what we should be testing for, what the risk is with these genes, and it's publicly available. It's called the National Comprehensive Cancer Network, or the NCCN. And if you can actually just Google NCCN hereditary breast ovarian guidelines, you can get this nice table and all the information, including the information about how your risk should be managed if you have a BRCA1 or 2 mutation. So when I see patients, I say, a lot of what I'm telling you is not just my opinion, it's actually the opinion of the consensus of all the national experts in this topic, based on one, what are the risks associated with the gene, and secondly, how you should manage that risk. So let's just spend a few minutes now, and then there are other genes which can be tested for that are more specific for ovary cancer, which may not be associated with breast cancer. So let's just spend 1 minute because there's some confusion of this and it's a little bit of a complicated topic, but I wanted to give a couple of highlight points for those who get a test and want to interpret the test. And this is actually confusing both sometimes to providers as well as to patients. So we have something called a gene like BRCA1 and 2, which can be associated with risk. The variant refers to the individual variation of the gene that's in your family, right? The variants are kind of like fingerprints. They can be different from one person to the another. And some of the variants, like fingerprints, are totally benign. They don't mean anything, but some of them are associated with cancer risk. And if you ever get this test to get a test report, there's 5 ways each gene and variant is classified. The important thing to know is really this. The word pathogenic means that there's very strong data that the variant that you carry of this gene is associated with cancer risk. And so they don't put this word pathogenic or the word likely pathogenic unless it's associated with elevated risk. However, there is something called a variant of unknown significance where we don't have a lot of data. The most important thing is that these VUSs are very common. Many of you who may have had a genetic test might have a VUS. The vast majority of VUSs are benign. They're just like fingerprints. They're different from one person to the next, but are not risk associated. And most companies, if a VUS is ever found to be risk associated, the provider will be contacted, as will, and the provider will contact the patient. But VUS, the vast majority are benign. So let's just review briefly how we manage risk with BRCA1 and 2, because these are the mutations that are most common in the Ashkenazi population. So starting at age 25, women should have at least twice yearly clinical breast exam, but most importantly, starting with breast MRI, which, as you may know, is a functional test of the breast tissue, which involves injection of a dye. This is really the best screening protocol and method for women who are young, because mammogram, which is simply an X-ray of the breast, does not see through breast tissue in young women because of its density. After age 30, mammograms become more interpretable, and mammograms and MRI are complementary screening methodologies. Because of their risk, many women could undergo prophylactic mastectomy, and we'll talk about the pros and cons in a moment. From the point of view of ovarian cancer, still to this day, unfortunately, we do not have good screening. Ovarian cancer is often detected at a late stage, as was in the case of Lauren Kodak. And therefore, the main recommendation is at the right age to consider risk-reducing surgery. Some women undergo screening before they undergo surgery, but it's not a substitute for the surgery. So what do we know about prophylactic surgery for BRCA1 and 2? This is often one of the most difficult decisions a woman has to make, sometimes in her life, when she finds out that she might carry one of these mutations. First, starting with prophylactic removal of the ovaries and tubes. It has been demonstrated that this saves lives when done at the right time, demonstrated improved overall and disease-specific for survival. Much research is going on about potentially new ways to detect ovarian cancer. We hope that it will bear fruit in the near future, but until then, surgical prevention at the right time in a woman's life is the best approach. The breast is quite different because breast cancer is a poster child disease for early detection. Early detection works. Breast cancer is largely curable, and therefore, whereas mastectomy is a totally reasonable option for many women who carry BRCA1 and 2 mutations, screening is also an effective option from the point of view of the breast cancers can be effectively treated. And technically, we say that there is unclear evidence for improved overall survival, meaning that a woman is likely to do well long-term, whether she chooses the screening or the treatment approach. But the issue is that they're quite philosophically different. Now, I want to get to the really exciting part about what's new, and I think this really points the way into A, the importance of BRCA1 and 2, and B, the progress that's being made through the research and the science in this area. So there's been much study about the specific and unique nature of BRCA2 associated cancers. And one of the unique features of BRCA2 associated cancers, and interestingly, this applies to just about all BRCA2 associated cancers in both women and men, breast cancers, ovary cancers, pancreas and prostate cancers, is they have an inability to repair genetic damage, inability to repair DNA damage. They lack a pathway called homologous recombination, which is an error-free way that our chromosomes can repair and heal themselves. But it turns out in those cells, the tumors survive by relying on a second repair pathway that depends on an enzyme called PARP. So studies 15 years ago showed in the laboratory that cells that lacked BRCA2 associated tumor cells, were very sensitive to PARP inhibitors. Normal cells are not sensitive to PARP inhibitors because they rely on this homologous recombination. And that was created the hypothesis that BRCA2-associated tumors could be effective treatments for these cancers. And indeed, some of the first studies were done with BRCA1 and 2 associated ovarian cancer because of its lethality. And the first PARP inhibitor that was approved by the FDA was in 2014 for ovarian cancer. And now olaparib and 3 other PARP inhibitors are now a standard part of the treatment regimen for advanced ovarian cancer. Subsequently, a few years later, it was showed that PARP inhibitors can also help treat BRCA-associated metastatic breast cancer. In this case, however, what the PARP inhibitor was doing was prolonging the time to progression, but not curing and not necessarily saving lives, although it was an important therapy because it was A, more effective than chemotherapy, and B, much better tolerated than chemotherapy. But of course, the outstanding question was, can we actually cure more women with breast cancer, with BRCA2-associated breast cancers, if we start the treatment earlier? And that question, as I said, has been out there for 15 years. And it was just last week at the large ASCO International Oncology meeting that this question was answered. And this was a study called Olympia, where they used this PARP inhibitor once women were identified to have BRCA1 and 2 mutations. The key was that they had to know their status, and they developed breast cancer. For this clinical trial, because it was, an experimental, effectively approach, it was the women who are at highest risk for relapse, but the breast cancer was still confined to the breast and to the lymph nodes. So it was women who had lymph node positive breast cancer, large tumors, and triple negative breast cancer, those who had the highest risk. All of those women, essentially, almost all of them, received chemotherapy in what we call the adjuvant or neoadjuvant therapy. That is, they received it as trying to increase their chance for cure. And the clinical trial was a randomized clinical trial of either giving those women a placebo or giving them this olaparib for 1 year after they had completed all the best known standard therapies. And so typically in a clinical trial like this, they do something called an interim analysis. Let's look at this point in time if there seems to be a difference. And if there's no difference, we're going to look later and see. We're going to look later and see, because over time, sometimes the differences can be apparent. Well, this is one of the clinical trials that the difference was so apparent at the first time that they looked. The trial has been stopped, and now the use of olaparib will become the new standard of care for women with high-risk BRCA-associated early breast cancer. So I want to walk you through just a couple of numbers to tell you why this is such a groundbreaking discovery. What it showed was that within 3 years, which for the point of view of breast cancer was a relatively short time, women who received only the best care possible without olaparib, 20% had already relapsed with distant metastatic disease. As you may know, distant metastatic breast cancer is largely an incurable disease. But at that time, 87% of the women who had olaparib were disease-free. So this was a 40% relative decrease in the women who developed metastatic disease at 3+ years, meaning a 40% decrease in the women who were likely ultimately to die of breast cancer. And the other flip side, 40% increase in the women who are likely to be cured of their breast cancer with the addition of olaparib. And even at this early time point, although the statistics will require longer follow-up, substantially fewer breast cancer deaths already occurred within 3 years with olaparib. This all providing strong evidence that olaparib is going to be one of the most important tools to save lives from breast cancer. But we already know from the studies that primarily these drugs, PARP inhibitors like olaparib, work if you have BRCA1 and 2 mutation-associated breast cancer, which makes it absolutely imperative if you have breast cancer in particular, to know your BRCA status, because there is now more effective treatment, particularly in early stage breast cancer. And this is really a dramatic result and one of the most important results in all of breast cancer in recent years. So I just want to close with the summary. I've talked about family history, knowing family history on both sides, and your ancestry, particularly your potential for Ashkenazi Jewish ancestry because of the high rate of BRCA1 and 2. Hereditary breast cancer risk genes are not the majority of people. It's a relatively small proportion, but finding them is important. And I hope I've told you all the reasons why that's the case. For these reasons, because it's becoming so much more important and life-saving, genetic testing is becoming more common, more informative, and over time, we want to be sure that everyone has access to this testing who needs it, that risk management based on inherited cancer risk can save lives, and that cancer treatment and survival can be improved by finding inherited gene mutations, with BRCA1 and 2 being the best example of this. So thank you for listening. I'm happy to take any questions.
Thank you, Dr. Ellisen, and thank you for sharing that important update. We had one question related to what you just presented, and it might be too early to even give a comment on it, but as it relates to this PARP inhibitor, what do you see anything on the horizon? And I know most ovarian cancers are detected later, and I'm sure you were expecting this question. Do you see any, are there any research studies or studies being done as it relates to ovarian cancer and the success of this PARP inhibitor?
Absolutely, and it's really, really an outstanding question. It turns out that, among the most aggressive cancers there are ovarian cancer and pancreas cancer. And in both cases, ovarian and pancreas, they're associated with BRCA gene mutations in some cases. And in both cases, we don't have good screening tests, and they're usually diagnosed at a late stage. Right. And so the clinical trials that have been done are somewhat parallel for both ovarian cancer and pancreas cancer associated with BRCA2. And in both cases, what it has shown, and it's a similar trial design to what I showed you for the breast cancer, the patients got all the best chemotherapy, all the best treatment possible, and then got the PARP inhibitor in addition, that indeed the PARP inhibitor is very effective in that setting and appears to be saving lives. We believe that to the extent that we can get better early detection and bring all of that therapy, both the standard therapy and the PARP inhibitor, to treat the disease at its earlier stage, we will save even more lives. But it appears to be exactly analogous. And the earlier you get the PARP, the more lives that are going to be saved for all of those contexts. And likewise, the same is probably true for prostate cancer as well.
Mm-hmm. Mm-hmm. And as a follow-up to that, speaking of clinical trials, how would you suggest, if folks are diagnosed and whether it's with breast, ovarian, or another hereditary cancer, somebody was asking, how would you go about having a conversation with your oncologist, or how do you go about finding clinical trials? I mean, certainly we do point folks at Oneinforty, but is there anything we might be missing as an organization where you might can help us fill that gap?
Yes, it's an excellent question, and all of you can see by everything that I've talked about was all the result of clinical trials to move the field forward. And I think any cancer patient should look into what options are available for clinical trials. And one of the best resources is there's a national website where all clinical trials have to be registered, and it's called clinicaltrials.gov. Clinical trials is one word, clinicaltrials.gov, and it's put up by the National Institutes of Health. Any clinical trial that we or anybody does has to be on there. They have a pretty good searchable format for searching by disease, searching by drug, searching by disease setting, and that is a very comprehensive way to know about updated trial information. And I think one of the advantages, if any, of now living in a Zoom world that we all live in now, is it has lowered the barrier to some folks for getting expert consultation if you happen to be someone who doesn't have access to a major specialty center where you can go physically to consult with all the experts. Many centers now are arranging Zoom consults where they can go through your history and recommend what trials might be available. You know, until recently, you might be traveling all over the country, particularly if you were in an area without a major center nearby to get an opinion. And now often one can do that remotely. So that's another thing. Look at some of the major centers, you know, whether it's Boston, you know, New York, Houston, you know, elsewhere, and see if they do remote consultation. You know, and I recommend all cancer patients to seek out what might be options for clinical trials.
Sure. So we have two more questions, and I think we have time for those. The first question is, would a PARP replace how tamoxifen is used for a patient after breast cancer as a preventative treatment for BRCA patients?
In a patient who's never developed breast cancer, it's an excellent question. So there's two aspects of it. I'll talk about treatment and then I'll talk about prevention. So I didn't say in this clinical trial, but I should have, that this clinical trial that I presented was both hormone receptor positive and triple negative breast cancer patients. For hormone receptor positive patients, they were given their standard hormone therapy in addition to the PARP inhibitor. And the PARP inhibitor is not used instead of standard hormone therapy. It's used in addition to standard hormone therapy, such as tamoxifen. So that therapy is still important. As the question may relate to prevention, as many folks know, tamoxifen and other drugs that are hormonal drugs can be used for breast cancer prevention. They have been shown to have some effect, particularly for BRCA2 associated breast cancers, not so much for BRCA1 associated breast cancers. The question of PARP for breast cancer prevention is one that many of us are interested in asking. But because PARP can interfere with a genetic repair and repair of genetic damage, there's concerns about potential longer-term side effects that may be extremely rare and certainly warrant use in cancer patients. It's not entirely, it's still somewhat controversial whether we have enough safety data, you know, even after 7 years of PARP inhibitor approval, whether we have enough safety data to use PARP inhibitors to try them for prevention in women who have never had cancer. And that is a very active area of investigation. And we hope that at some point in time, PARP inhibitors used in the right way will be proven to be safe, not only for treatment, but also for prevention.
Thank you. So we'll end with this last question for you, Dr. Ellisen. And it's a question we get here at Oneinforty. Obviously, you know, we are working hard to educate primary care physicians about the 1 in 40 risk. So this question comes as, you know, for high-risk patients who do not know yet of a cancer diagnosis, they've observed that primary care physicians are not always, you know, attentive to making referrals for genetic counseling and testing. So if folks walk away from this program tonight, and they're interested, you know, they have the knowledge now, they've made the decision to get genetic testing and screening, they approach their PCP, and, you know, we're not saying that all healthcare providers do this, but if there is some pushback, how, you know, can you give some advice on how to navigate that for our community?
I think it's an excellent question, Allison, and it's one that we all struggle with, making sure that referrals are made appropriately. You know, I think number one, I would say that, make your primary care doctor aware, right? Primary care doctors have all the boxes to check, so many things to deal with in a short appointment, right? And so, you know, one of the best things a patient can do is to bring the family history, bring the concern to the forefront about the risk and about the potential necessity for testing. So that's number one. Number two is discuss with multiple providers. Sometimes, for example, if a woman sees a gynecologist, you know, the gynecologist, because they might be more aware of some women's cancers issues, sometimes tend to be more amenable to or more familiar with the referral process. So if you're PCP, bring it up to your gynecologist. And the other thing I would say is that there are commercial providers that will allow you to self-refer for testing. Among them are Color Genomics, which does a good job of informing people at a relatively cost-efficient way to get those test results. And then to make the appropriate referral for the right counseling. In those cases, I would say, you want to be sure that once you get your test result, that you bring it to an expert to be sure that it's interpreted correctly. Because, the two steps that we see are the one you mentioned, getting the testing in the first place, and then the second, to be sure that you get the right interpretation, not have it overinterpreted in terms of assessing too much risk or underinterpreted. So I think both of those steps are equally important. But it is a world, and I have to say it honestly, that this is a world where patients have to be their own advocates, because the medical community, you can quote me on it, are not doing a good enough job at getting access for testing for everyone who needs it. We need to do a better job in the medical community, and at this time, patients need to be their own advocates as the system tries to, improve our practices.
Right. Thank you so much. And I think, the takeaway from that, I think what was really important for our attendees to hear also is, there's other ways to go about it, whether it's through your primary care or, if you are a female, through your OB, or if you are, a male, the other kind of providers you're seeking care or treatment from can help you to navigate through this. I wanted to thank you so much, Dr. Ellisen, for your time this evening. I learned so much more this evening, and thank you for sharing that. The new research that was just done, and the new outcomes of that. And thank you for taking this time this evening. I wanted to let folks know, to visit Oneinforty for more information. We are planning our calendar for the fall. We're going to take a break over the summer so everybody can enjoy their summer, their families, and their friends. And really, thank you for taking the time to tune in to us this evening. We really appreciate it. And thank you once again, Dr. Ellisen.
Thanks to everyone who joined, and thanks to Oneinforty for all their important work.
Thank you. Take care, everybody.
Bye-bye.
Bye.